Hello, I would like to welcome everyone to the IBM Watson Health Executive Webinar Series. Today's presentation is titled Preparing for Comprehensive Primary Care Plus, presented by Donna Daniel, Senior Program Director of Clinical Quality Research at IBM Watson. Before we begin, I would like to review a few housekeeping items. First, you have a control panel on the right side of your screen. You can minimize and expand this panel by clicking on the arrow in the upper right corner. Second, you can submit questions using the question panel located near the bottom of your screen. We will try to answer as many questions as we can at the end of the presentation. If your question was not answered, we will respond to you individually after the event. Finally, all registrants will receive a copy of this presentation and the link to the recording within 2 business days after the webinar. The information will be sent to the email in which you registered. Next, I would like to introduce Dr. Donna Daniel. Donna has her PhD in biometry and epidemiology from the Medical University of South Carolina, as well as trained at the Institute for Healthcare Improvement. She worked for over a decade with the Centers for Medicare and Medicaid Services, supporting its quality improvement efforts, and has led national and regional practice transformation efforts, including chronic care collaboratives for the American Academy of Family Physicians. She serves as the Senior Program Director for Clinical Quality Research at IBM Watson Health and previously worked at the American Medical Association as Director of Improving Health Outcomes Strategies. Today, Donna will provide an overview of CMS latest care delivery and payment redesign models, the Comprehensive Primary Care Plus. Donna, the floor is yours.
Thanks, Sean. One more housekeeping item. This slide shows, quote, our fine print, and wanted to make sure I'm meeting our recommendations from our legal team. Before I jump into the formal presentation, I wanted to start with a polling question. And so I'm going to ask those of you who are on the webinar to respond to this polling question. Sean's going to open the poll now. The question is, how many of you are at an organization that is planning on submitting an application for the Comprehensive Primary Care Plus? And our options for responses include definitely planning to submit an application, possibly, probably not, I don't know, or you are not a member of a practice, and then you can simply click not applicable. So while you are responding to the poll, I'd like to thank Kathy Burkham for her role in developing this slide deck. Kathy is part of IBM Watson Health's clinical informatics team in Dallas, and they serve as subject matter experts for the clinical content and health policy, which are the foundation of our population health management products. Next, I'd like to acknowledge IBM Watson Health's commitment to the quadruple aim of improved quality of care, reduced cost, increased patient engagement, and improved provider care team experience. IBM Watson Health is a health IT vendor for CPC Plus, and we would welcome an opportunity to be one of your IT partners in Comprehensive Primary Care Plus if you choose to apply. All right, so Sean, can we see the responses? I'm not sure. Are folks able to see? Okay, I see. All right. So we've got a good group where this is not applicable, and a good group that are saying, I don't know, possibly, followed by definitely. So this is a nice mix. I hope that for those of you who are falling in that category of probably not or I don't know, I hope that today's information is helpful to you, and for the others that it reinforces that moving forward in applying for this program is a good move. We'd be happy to answer any questions. Sean is going to serve as our contact on the webinar, so please feel free to reach out to her, and she will triage any questions you have about the content we're going to talk about today. So I am joined by Dr. Bill Kassler. He is formerly the Chief Medical Officer for the New England region at the Centers for Medicare and Medicaid Services. Dr. Kassler also spent many years working in the CMS Innovation Center, developing and testing new models of paying for population health. So you can see why it's great that I've had the opportunity to have him join. Bill joined to IBM Watson Health as Deputy Chief Health Officer and Lead Population Health Officer a few months ago, and I'm excited to have him set the stage with some opening remarks. So I'll turn it over to you, Dr. Kassler.
Thank you so much, Donna, and good morning to all of you on the webinar. It's a pleasure to join you electronically. We all know that the current health system faces serious challenges. Healthcare is too expensive, and our payment system incentivizes volume over value. We have a system that also focuses more on the delivery of health care and insufficient attention to the behavioral, social, and environmental causes of poor health. And within healthcare, our system is fragmented and results in waste and a level of quality and patient safety that has serious room for improvement. And then, as Donna mentioned on the fourth aim, that system is neither responsive to patients, caregivers, or providers. So a major policy strategy to address these challenges, which is favored by health policy experts, is to strengthen primary care. Specifically, to enable primary care practices to deliver better value care by becoming advanced primary care medical homes. CMS recently unveiled the Comprehensive Primary Care Plus payment model, the latest in its portfolio of demonstration projects under the authority of CMMI, or the Center for Medicare and Medicaid Innovation, to design and test new models of care and payment that achieve the triple aim: higher quality, lower cost, and better health. CPC Plus model builds on the earlier CPC model, using a multi-payer approach to support primary care practices. That earlier model showed promise. Participating practices achieved improvements in quality and patient experience, but the net Medicare spending did not decline. There was some modest decrease in spending at the inpatient care level, but just not sufficient to offset the care management fees that CMS paid. So as a result, CMMI plans to roll out the new CPC Plus model to more providers in more regions beginning January 2017. And that model will offer the same basic structure but some additional choices to practices in the form of higher payments for more advanced capabilities. So will this new model be better for primary care practices than the existing chronic care management fee? Will participating primary care practices qualify for incentives under MACRA's alternative payment model? And how will this program interact with existing Medicare ACOs? To answer those and many other questions, I'm going to turn the baton back to Donna. Thank you so much.
Great. Thank you, Bill. Much appreciated. All right. So jumping in here, this slide shows the proposed Medicare and CHIP Reauthorization Act. It describes the Quality Payment Program, or the QPP, as CMS is calling it. And there are two parts: the Merit-Based Incentive Payment System, or MIPS, and the Advanced Alternative Payment Models, or APMs. And as you can see, CPC Plus is one of just a handful of advanced APMs, or alternative payment models, listed on the right-hand side of your screen. These are those that qualify as advanced alternative payment models. Practices billing Medicaid will need to select between MIPS and the advanced APMs beginning as early as 2017, with the payment model going into effect in 2019. I should mention that there's talk that 2017 will be a transition year for the Quality Payment Program. However, CPC Plus is scheduled to begin January 2017. And on April 11th, 2016, the Centers for Medicare and Medicaid Services announced the launch of a new advanced primary care medical home model they're calling Comprehensive Primary Care Plus. this CPC Plus program is designed to contribute to the following two goals of the administration. Those are that 50% of Medicare fee-for-service payments will be paid via alternative payment methods by 2018, and that they want to achieve improved quality and value of care for Medicare beneficiaries. This is essential to creating a healthcare system that is delivering better care, spending our dollars more wisely, and leading to healthier Americans. And if this is successful, the CPC Plus program is predicted to save up to $2 billion in healthcare expenditures by 2022. So as Bill mentioned, the CPC Plus is based on its predecessor, the Comprehensive Primary Care Initiative. That's a 4-year multi-payer initiative that was designed to strengthen primary care. And it's going to end on December 31st, 2016. Through this original CPC initiative, CMS is collaborating with commercial state health insurance plans in 7 regions to offer population-based care, management fees, and shared savings opportunities to the participating primary care practices to support the provision of a core set of 5 comprehensive primary care functions, hence the name CPC Plus. CPC Plus integrates many of the insights from the original CPC initiative, including the critical role of practice readiness, aligned payment reform, actionable performance-based incentives, and robust data sharing. So, what is Comprehensive Primary Care Plus? It's a new regionally based, multi-payer primary care delivery and payment redesign initiative. That is, to date, CMS's largest investment in advanced primary care. It's a further transition to value-based payment models and introduces primary care practices to risk-based payments in an incremental manner. It's a 5-year model that I mentioned will begin January 2017. It consists of 2 tracks with care delivery requirements and payment methodologies that progress from track 1 to track 2. This design allows options for primary care practices with varying levels of practice transformation experience. CMS intends to recruit 2,500 practices in each of the track, or a total of 5,000 practices across 20 regions. Payers of various types, including commercial insurers, Medicare Advantage plans, Medicaid CHIP managed care plans, self-insured businesses or administrators of self-insured groups, were all invited to respond to the CPC Plus solicitation for payer partnership, and that closed in June. CMS is going to enter into a memorandum of understanding with the payers to ensure that the payment models are aligned with Medicare's, and I'm going to share with you today what Medicare is proposing as its payment model. And it's important to note that they deliberately use the word aligned because they did not want to declare that the payers had to have identical payment models. And this is to allow the flexibility for the payers to be able to implement payment approaches that align with the needs of their members. In addition to engaging payers, CPC Plus includes a strong commitment from health IT vendors, given the focus on population health and care coordination. So practices that are applying for CPC Plus, specifically those applying for Track 2, will need to also submit a letter of support signed by all the IT vendors the practice is working with. And there's a templated letter available on the CMS website, and at the end of the slide deck, I provide CMS's contact information for this program. Also, once practices in Track 2 are recruited, the IT vendors will sign an MOU with CMS demonstrating our commitment to the program goals. So again, IBM Watson Health is interested in partnering with you and your EHR vendor in CPC Plus. Like the original initiative, practices participating in CPC Plus will implement a care delivery framework. This is the practice transformation component. It's based on 5 comprehensive primary care functions, and I'll just list those now. Access and continuity, care management, comprehensiveness and coordination, patient and caregiver engagement, and planned care and population health. And in a moment, I'm going to spend time going through these different functions and what examples look like of what the practices will be expected to do. So practices are also going to be evaluated on patient experience measures, clinical quality measures, and utilization measures. And then participating practices will receive technical assistance through national and regional learning communities, which are going to offer in-person, virtual, and on-demand educational programs and online collaboration tools to facilitate peer-to-peer sharing. So that was a lot of information and an overview. Just to recap, this is a 5-year initiative starting in January 2017. There are 2 tracks. It's multi-payer. Practices partner with their health IT vendors. Practices implement the care delivery framework consisting of 5 functions. CMS will provide technical assistance to all participants, and practices will transition from volume-based to value-based payment models. All right, so let's spend a moment on the timeline. The timeline for CPC Plus began with the announcement in April, followed by the closing of the payer solicitation in June. And originally, this might be new news for some of you who have been following CPC Plus, originally CMS intended to release the list of payers by region, identifying up to 20 regions by July 15th. However, this has been delayed, and CMS expects to release the regions at the end of July, any day now. So we can check the CMS web page today. And on August 1st, practices in these regions that are named would apply using an online tool for either Track 1 or Track 2. And interested practices must complete the online application by September 15th. So CMS has a paper version of the application in Appendix B of their request for application, or RFA. And the practices will be selected in October, and then the program will launch in January. So Bill mentioned, and I also mentioned, that CPC Plus is based on lessons learned from the original CPC initiative. The table on this slide is from a journal article published in JAMA and shows the differences between these 2 programs, including differences between the tracks. So I'll go through some of these differences. There's differences in size. So the original CPC initiative included approximately 500 primary care practices in 7 regions. CPC Plus is expanding to support up to 5,000 practices in up to 20 regions. Another difference is in duration. CPC is a 4-year model and account for the time that practice transformation takes. The duration for CPC Plus is 5 years. Also, CPC Plus has 2 tracks. CPC, the original, included a single model of practice requirements. CPC Plus is offering 2 tracks with varying practice requirements and varying payment models. The care delivery frameworks are very, very similar, with just some slight revisions to the 5 functions that I named. However, in Track 2, practices are encouraged to focus on improving care for patients with complex medical, behavioral, and psychosocial needs. So if you're trying to figure out which track you're in, think about that. CMS modified the payment model based on the learnings from the original CPC initiative. This included moving away from a regional shared savings and having in CPC Plus, having a 3-part payment model that will go directly to the practice. So first, practices will receive a monthly care management fee. Second, a performance-based incentive payment that will be paid directly to the practice. This is based on quality patient experience and utilization measures. And these measures are calculated at the practice level and are more actionable. The measures that they are identifying are more actionable for primary care practices. So again, all lessons learned from the original CPC. And finally, there are modifications to the payments under the Medicare Physician Fee Schedule. Actually, Track 1 practices will continue to bill and receive payment from Medicare as usual, but the Track 2 participants will continue to bill as usual, and a portion of these bills will be transitioned to what CMS is calling a comprehensive primary care payment, or a lump sum that is paid on a quarterly basis. Finally, that CPC payment, those amounts are going to be larger than the fee-for-service would have been, because they recognize that they are asking Track 2 participants to support more comprehensive care delivery, and they recognize that the financial incentives that need to come with that. Also in CPC Plus for Track 2, CMS will require practices to engage more directly with IT vendors to achieve the model goals and requirements. Okay, so let's talk about the goals. There are 3 main goals of CPC Plus. First, to advance care delivery and payment to reduce cost of healthcare and reduce unnecessary healthcare utilization. To accommodate practices at different levels of transformation readiness by offering 2 tracks and providing healthcare teams with resources, information, and financial incentives. And then to achieve delivery care reform through ideal population health management and chronic disease management. So CPC Plus seeks to support providers and care teams by redesigning the payment structure so that practices can have upfront cash flow. These dollars can be used to hire and train staff to provide care more effectively and efficiently. They also can be used to support technology, and by creating their online learning consortium, they're providing support to practices who want to use those dollars in that way. And the predicted outcomes will be reduced CMS program expenditures and improved quality of care for Medicare beneficiaries. Providers and care teams can use that upfront money, which is allowing for more flexibility in their care delivery. In many places of the request for application, CMS indicated that they wanted these dollars to allow providers to transform their practices by building capabilities and developing care processes that will deliver high-quality, whole-person-centered care that uses less money and no unnecessary services. So, for example, CMS is very interested in supporting appropriate non-visit-based care. So if you want to get creative with phone calls or e-visits, etc., those dollars could be used to cover your care team's time and resources. So this slide is from the CMS Library of Resources, and it shows the components of the framework for the CPC payer partnership. First is enhanced non-fee-for-service support in the form of that monthly care management fee that I mentioned. For Track 2 practices, there will be an incremental transition over the 5 years to move to a partial fee-for-service, partial alternative payment methodology approach, and that's through the Comprehensive Primary Care Payment, or CPCP, and that's that payment that's in the form of a quarterly lump sum. And then practices will also have the opportunity to keep upfront performance-based incentive payments if they meet the annual performance thresholds based on those quality patient experience and utilization measures that I mentioned. But it's important to note that if the practice does not meet the performance thresholds, the practice pays a portion of these dollars back. So there's the at-risk portion of this payment model. So CMS is signing MOUs with payers to encourage alignment so that everybody is asking the practices for the same or similar information and has similar payment tied to it. Finally, CMS and the payer partners are encouraged to share practice and patient level cost and utilization data to the practices. So if your systems currently are not providing you with the cost and utilization measures for the results on the measures, for example, that you're being held accountable to in this program, CMS and the payer partners are going to be providing reports to the practices. So now let's talk about how this, how the application process works. So if there turn out to be more than 2,500 practices that apply for a given track, CMS will use a lottery approach to determine who gets those slots. Practices that are not selected may be used in a control group, and CMS would reimburse for time and resources that these practices are spending on sharing data or completing assessments or other information used in the evaluation. CMS is committed to supporting and building on innovative payment and service delivery models, so it is prioritizing the 7 regions from the original CPC initiative, as well as prioritizing 8 states that have participated in the multi-payer advanced primary care demonstration. So that was another advanced primary care program that CMS supported, and they want to continue building on both of these programs. Also, states that receive state innovation models will be prioritized, and to make sure that they get a group of practices that are diverse, CMS is focusing some attention on practices with fewer than 50 physicians and are independent. So if you have a question about what states those are, please put that question in the question or chat function, and we can share that with you. All primary care providers, they are defined as physicians, nurse practitioners, physician assistants, or clinical nurse specialists. All primary care providers billing at a practice site must participate. And what I mean by that is CMS views all providers as participating, whether they truly are engaged in your transformation efforts or not. And so when they are looking at the scores on measures to determine payment, they are going to be looking at all of the primary care providers within a practice. And because CPC Plus is designed to model payment reform for traditional fee-for-service payment models, rural health clinics and federally qualified health centers are not included or qualified to participate. And this is because they have a different billing process. They're not in that traditional fee-for-service world. Okay, so requests for applications, as I mentioned earlier, will now open on August 1st and close on September 15th. Eligibility for track 1 and 2 are described here on this slide, and in addition to demonstrated use of certified electronic health record technology and partnering with payers, both tracks are required to demonstrate track appropriate readiness, or practices applying for both tracks need to demonstrate readiness in the following areas. Those are empanelment, or the ability to attribute or assign patients to a provider care team, 24/7 access by either the care team or the covering care team with access to the medical record, and quality improvement. Track 2 providers will be required to provide more comprehensive services and assume more risk for patients with complex medical, behavioral health, and psychosocial needs, and complete comprehensive assessments of their resources available to meet all of their patients' health and psychosocial needs. And then appropriately so, payment incentives are going to be higher in Track 2 because of these higher expectations. While practices will indicate a preference for Track 1 and 2 in their application, CMS reserves the right to ask a practice that applied to Track 2 to instead participate in Track 1 if they believe that they are not meeting the eligibility requirements for Track 2. This slide covers the ways in which health IT vendors will engage with practices. So I mentioned that all participating practices, regardless of track, must use certified electronic health record technology. Practices in Track 2 will use the CMS supplied template to submit a letter of support signed by all health IT vendors as part of the application process. And CMS will sign a memorandum of understanding with all of the involved health IT vendors. And again, to ensure that as health IT vendors, we're committed to supporting the goals, the implementation, achieving the goals and the implementation of the 5 comprehensive primary care functions. And then the vendors are also invited to and can participate in that learning consortium that I mentioned, both at regional and national level. Okay, so earlier I mentioned that there are these 5 comprehensive primary care functions that serve as the care delivery framework for CPC+. So these are the areas in which your care team would need to be focused on making modifications to care delivery. And these 5 functions are the same for both tracks, but it's the specific requirements within each of these 5 areas where you'll see the differences with more extensive expectations for the Track 2 participants. So let's go through some of those. So this slide and the next slide are from CMS, and they provide examples for what's expected of Track 1 and Track 2 sites. Both tracks, the way you read this is that both tracks complete the activities in the examples under the first column that's labeled examples for Track 1. And then Track 2 is expected to take on those that are listed in the last column labeled additional examples for Track 2. So for example, practices in Track 1 and Track 2 must ensure 24/7 access to a member of the care team or covering care team with real-time access to the electronic medical record. However, Track 2 participants must provide at least one alternative visit method, and those, some of the examples listed are e-visits, phone calls, group visits, house visits, expanded hours, or telehealth. For care management, both tracks must have the capability to risk stratify and identify those with higher risk and provide targeted proactive care management, plus provide medical reconciliation for those with emergency department visits or hospital admissions. And again, Track 2 needs to be able to, in addition to all of that, work with the patient and family members to design care plans for those high-risk chronic disease patients and carry those out. The function of comprehensiveness and coordination, that is defined as care which meets the majority of physical and mental health needs and includes coordination with specialty care and community services. And the goal here is that providers and care teams participating will know where in the medical neighborhood their patients are receiving care and will organize the practice to facilitate the coordination of that care. So practices in both tracks will address the opportunities to improve transitions of care by working more closely with hospitals and emergency departments, as well as with at least one high-volume specialty care provider. And because Track 2 practices will not be paid through fee-for-service alone, they will have the flexibility to offer more comprehensive services, such as a systematic assessment of patients' psychosocial needs and establish an inventory of resources and supports that meet those needs. So again, looking in the community to see what is available and ensuring that the care managers have a referral process in place. All right, so this next slide will go through patient and caregiver engagement and planned care and population health. So for patient and caregiver engagement, all participants will engage patients and families in the design and improvement of care using patient and family caregiver advisory councils, or other strategies to elicit the voice of the patient and integrate the patient into efforts to improve care. Practices will also engage patients in goal setting and shared decision making using decision aids and specific techniques like motivational interviewing to support patients in the process. And Track 2 practices may also work more directly with the patients and families in quality improvement initiatives, and then must provide self-management support as well as support for caregivers of persons with functional disabilities. And the example they provided was dementia. And then finally, for planned care and population health, all practices are expected to proactively offer timely and appropriate preventive care and reliable evidence-based management of chronic conditions. Track 1 and 2 practices will develop an understanding of their patient population. That's referring to the impaneling of patients, the attribution of patients to a care team, and then develop the capability to measure and act on the quality of care at both the practice and panel level. Panel level meaning the provider care team level that the patients are assigned to or working with. But the Track 2 practices will also need to integrate self-management support into their routine processes and understand and address health disparities in their population. And they did not go into detail on further on what those look like. So I think that's at least right now, that's at the practice's discretion. So this next slide shows the codes that will be used to identify and attribute your Medicare beneficiaries on the Medicare side. So not only are we expecting, not only is CMS expecting that practices have a way to assign patients, attribute patients to providers and care teams, CMS is also going to apply a methodology. And then they are going to look at primary care claims over the prior 2 years to identify the population of Medicare fee-for-service beneficiaries for which each participating primary care practice is accountable. And then CMS will run attribution lists for the applicant practices before they sign their participation agreements. And so if you are identified as one of these 5,000 practices that is participating or is invited to participate into CPC Plus, Medicare will give you their list ahead of time for you to review and discuss. So if you'd like more specifics on the attribution methodology, see Appendix E in the request for application, and again, that can be downloaded from the CMS CPC Plus website. Okay, so Now we're going to move into the specifics on the payment model. This table right here describes the 3 payment components to support practice transformation. It refers to what Medicare is going to pay or is proposing to pay. However, at this point, we do not know for sure how much or in using what model the other participating payers will pay. So I just wanted to highlight that. The first payment component is the care management fee. Both tracks will receive the care management fee, and this is applied to each Medicare fee-for-service beneficiary per month. Neither track will be allowed to bill for the chronic care management. So there's a chronic care management program. You get $40 per Benny per month for those who have 2 or more chronic conditions, and the practice provides 20 minutes per month or more of care management. You will not be able to bill for that program if you currently are and you join CPC Plus. And the reason is because this care management fee covers that, and that would be viewed as double dipping. So monthly prepayments are provided up front, and again, to allow the flexibility of providers. And this is covering non-visit based fees, and it's paid per beneficiary per month. The amount is risk adjusted for each practice, and that allows us to account for the intensity of the care management services that are required for your practice's specific population. And my next slide will go into a bit more detail on the risk tiers and the payments associated with them. This second column describes the performance-based incentive payments. I mentioned earlier, this is where the at-risk part comes into the model. CPC Plus will prospectively pay and then retrospectively reconcile a performance-based incentive payment based on how well the practice performs on the patient experience, clinical quality, and utilization measures. Again, practices will be at risk for the amounts prepaid, and CMS will recoup unwarranted payments. The payment will be broken into 2 distinct components. Both are paid prospectively, and those are the incentives for performance based on clinical quality and patient experience measures, and then the second is are the incentives for performance on the utilization measures. CMS will provide larger payments that you see that demonstrated here on the table. So larger payments in track 2 than in track 1, and that, again, that's because of the higher level expectations with respect to quality and utilization. And then finally, for the payment under the Medicare physician fee schedule, track 1 will continue to bill and receive payments as usual, so that's standard fee for service. But track 2 practices will, while they'll also continue to bill as usual, the fee for service reimbursement amounts will be reduced to account for CMS shifting a portion of these Medicare fee for service payments into what CMS is calling the CPCP, or Comprehensive Primary Care Payment. And those are going to be paid lump sum on a quarterly basis, as I mentioned, absent a claim. So given the expectations that the practices in track 2 are working on, this will allow, this payment, the expectation is this payment will allow for that increase in comprehensiveness of care that's being delivered. And again, the CPCP amounts will be larger than the fee-for-service reimbursement amounts that they are replacing, because they are realizing that there needs to be more money here. So we're gonna walk through an example in just a moment. So on our next slide, as promised, we get into a little more detail on that care management fee and the determination by risk tier. So we have, So patients are going to be allocated to one of these tiers. There are 4 tiers in Track 1 and 5 tiers in Track 2. They're based on risk quartile in Track 1, and the dollars are assigned as you see described on this slide. So CMS will run the attribution methodology using the past 2 years of claims to identify your practice's population of Medicare fee-for-service beneficiaries, and risk will be determined by many factors. So age, gender, enrollment status, disability, they have a diagnosis of dementia or end-stage renal disease, plus an adjustment factor for each CPT-coded disease. So it is highly recommended that practices who are going to apply for CPC Plus or when accepted, that you ensure that your patient's conditions and diagnoses are accurately and fully reflected in the electronic health record. So the care management fee will be adjusted to reflect the resources that are required to care for patients with more complex needs. And that is to account for the increased labor and demanding requirements of your care team. So most care management fees will likely remain constant over the course of the program, or at least that's what CMS is anticipating, but they are going to monitor their assessment of risk and designation of your patients in these risk tiers, and if that is if it's showing not to be true, that they're staying constant over time, CMS may adjust that care management fee payment methodology. So for Track 1 practices, these risk tiers average out to be about $15 per beneficiary per month, and that again is paid up front, and that's to support your transformation efforts to move from volume to value. And then Track 2 practices, the risk tiers average out to $28 because there's this 5th tier where they're looking at the top 10% of those at highest risk or those with a dementia diagnosis, and that is paying out at $100 per Benny per month. So again, $100 per Benny per month for those patients attributed to the highest risk tier. And again, really to make sure that they're covering the costs or at least offsetting the costs for the complexity that is required to care for these patients. So prepayment provides that upfront cash flow that I think practices have been needing, and the flexibility for providers and and then the care management fee is intended to support new workflows, hiring of care management staff, time and resources spent developing new relationships necessary for the coordination of care, like with specialists or with community resources, technology to support population health and chronic disease management, training on new deliveries like non-visit-based care. So if you want to implement telehealth, there's going to take some time for your team to figure out what the process is for deploying a technique like that. Okay, so CPC Plus will prospectively pay, this is moving to the performance-based incentive payment. So CPC Plus will prospectively pay and retrospectively reconcile the performance-based incentive, and that's based on how well a practice performs on the quality, patient experience, and utilization measures. So CMS will prospectively pay a per Benny per month fee or incentive, but will only allow practices to keep the money if they meet the annual performance threshold. I have not seen any specifics on the thresholds at this point. The quality and patient experience component is going to be based on performance on e-clinical quality measures and CAHPS metrics. And then the utilization component will be based on claims-based measures of inpatient admissions and emergency department visits, which are available in the HEDIS data set, measure set. And there's a slide in here that will point you to where the list of measures is. CMS is prioritizing quality, so there is no utilization performance reward unless the practices meet the minimum total score for quality. So again, that's another important note. And on the slide, you'll see in the table that they are breaking out the payment, incentive payment for the quality. Again, that's the quality and patient experience, and the utilization to get to the totals of $2.50 and $4 per Bene per month. Okay, so the third component of payment is through the comprehensive primary care payments, or CPCP. These are lump sum payments made quarterly to practices in Track 2. And in Track 2 of CPC Plus, CMS is introducing a hybrid of a fee-for-service and a CPCP. And these comprehensive primary care payments will pay for covered E&M services, but it allows for the flexibility to deliver care both inside and outside of an office visit. The Track 2 practices will receive a percentage of their expected Medicare E&M payment up front. So again, there are upfront dollars here in the form of that comprehensive primary care payment, and then a reduced fee-for-service payment for the face-to-face E&M claims. To recognize practice diversity in readiness for change in payment, CMS is allowing practices to move to one of these final two proposed hybrid payment options at their preferred pace by 2021. So what they want to move to is they want to move to CPC at 40% with fee-for-service at 60%, or a CPC at 65% with a fee-for-service at 35%. And they've got a schedule on how to do that over time. And you'll note here that there's this 10% extra that's being included here. And so what CMS is proposing to do is to look at your historical fee-for-service claims and bills, and then add 10% of that, again, to compensate for the comprehensive services. So in 2019, under the proposed macro legislation, we recognize that it's proposed and it could change. The Track 2 practices are, actually I don't even think this is limited to Track 2. I think participating practices are expected to be exempt from MIPS and are going to receive the automatic 5% APM bonus incentive that is part of the advanced APM model. All right, so I promised an example. Let's assume that a provider, not a practice, but a provider, has 1,000 Medicare beneficiaries attributed to him or her, and we'll make another assumption that procedure billing and evaluation and maintenance billing each make up 50% of total billing. So again, just an example so we can look at some numbers. And again, I have to tell you that this there are unknowns here. I've been talking with CMS, and they shared that they are expecting to release the technical methodology for calculating these payments in late 2016. So this is subject to change, but just wanted to give you a little bit of a sense of what this is looking like today. So if we walk through this, again, this is per if we and looking at it across a year. If we look at the first row, which is labeled fee for service, this provider would receive $180,000 per year in E&M reimbursements. And since we assume procedure billing is half of the total, that's another $180,000 for a total of $360,000 under a traditional fee-for-service model. For CPC Plus Track 1, the provider bills E&M as usual, so that's $180,000, and gets another $180,000 for procedures. Assuming the average level of risk, back to that care management fee, equates to $15 per Benny per month, the annual care management fee dollars are another $180,000, and these are paid up front. Assuming this provider meets the thresholds for quality patient experience and utilization measures and receives the full $2.50 per Benny per month, that's another $30,000. Plus, if we add the 5% alternative payment model bonus under MACRA, we get to a total of $588,000. Under Track 2, with a risk-sharing arrangement, actually, I'm not sure that I should have referred to that as a risk-sharing arrangement. We're gonna assume the 65% with the comprehensive primary care payment and the 35% fee for service. The provider receives an increase in the historical E&M billing dollars of 10%. So we are going to say approximately $198,000 just for this example. And then the provider receives macro of the E&M billable amount up front and receives $180,000 for procedures, the 5% macro bonus. And then right now I am assuming that the macro bonus will be applied to the 10% increase as well, but that's unknown at this time. Assuming the average care management fee is at $28 per Benny per month, then the annual upfront care management fee is $336,000. And then if the provider meets all the thresholds for all the measures, and we are at a 4% per Benny per month payment, this equates to $48,000, and the total is nearing $800,000. So with over $450,000 available to you to hire staff, pay your staff for quality improvement activities, and I think, you know, really care for patients in the way that you want to care for patients. So I know we are getting close to time. I apologize for that. I'll move quickly through these next slides. Here are those measures, the measure set that I promised I'd share. This can be found in Appendix D of the request for application. These will be finalized in November of 2016. This slide shows the ways in which CMS will support the Learning Consortium. And this slide shows or mentions that, again, data feedback reports from CMS and the payer partners are going to be coming to you about your expenditures on claims-based cost and utilization. And as a partner, IBM Watson Health can work with your organization to look at what these data look like on your side. And then finally, this table shows how our solutions support CPC Plus. So you can see there's quite an opportunity for partnership, and we would welcome anyone to reach out to us and talk about this more specifically. Here's how you reach out to CMS. There's the link to the CPC Plus website. Again, that's where you can download the request for application, and it's got a lot of good information in its appendices. And so we are at the top of the hour. I will stop there. I believe Sean will be reviewing with Bill and myself the questions that you've chatted in. We will respond to those. I will also offer responses to the questions that Bill posed in the beginning. And with that, I will turn it back over to Sean.
Thanks, Donna. Did you want to take a couple seconds? There was a couple questions that came in. I figured we could do one or two of them.
Sure.
Okay. The first one was, you mentioned the chronic care management fee, which requires beneficiary cost sharing. Does the CPC Plus require beneficiary cost sharing?
That's a good question. It does not. So unlike the chronic care management fee, the CPC Plus care management, none of the CPC Plus requires any cost sharing by beneficiaries.
Okay, another one is, what is the value proposition for payers?
Another good question. So why do payers want to sign up with CMS to do that? To do this? I think that we're all understanding that, and evidence shows that by increasing patient engagement and improving quality of care will lower costs of care. And so as we're all embracing that, I think that payers are hopeful and expecting to see that they will, their clients, their members will receive a higher quality of care at a lower cost when the incentives shift from volume to value.
Great. And like Donna said, I have compiled all of your questions that are coming into the queue, so we will follow up with each of you on your questions and make sure you get the answers. I'd like to thank both Donna and Bill for their time today. And as a reminder, you will receive an email that includes both the presentation, handouts, and a link to the recording within 2 business days. And this email will also include the details and registration links for our next 2 webinars. And we also ask that once you log off today to take a brief survey to help us learn more about what was effective and where we can improve for our next presentation. Thank you so much, and we hope you have a great day.